So it's my pleasure to talk about the optimal role for bone-targeted therapy in the changing landscape of prostate cancer. And we're going to talk about these objectives for the program: to identify patients at risk for CTIBL, or cancer treatment-induced bone loss, and assess strategies to reduce the risk of bone complications. We're going to go over the evidence for the use of BTAs from early to late stages of prostate cancer, as well as understand the evolving landscape of M0 CRPC and implications for clinical practice. So it's a fairly robust program, and if you want to ask questions during it, I'm happy to take those questions, or you can just save it till the very end. The CUA WebEx program has received a generous financial support from Amgen and Janssen in the form of an educational grant. These are my disclosures for the program listed here. So just to start off, we're going to talk about the spectrum of metastatic CRPC patients. And if everyone can see my pointer, I hope you can. The landscape has changed dramatically for hormone-sensitive prostate cancer with ADT and docetaxel and high-volume disease. And we're going to talk a little bit today about latitude and the addition of abiraterone acetate and high-volume disease. And then the spectrum to M0 CRPC, and then to metastatic castration-resistant prostate cancer, failed ADT, mildly symptomatic, and then post-docetaxel. You can see this algorithm. We have abiraterone and enzalutamide in metastatic CRPC. Many of you have heard about this quite a bit and are using these agents quite avidly. And then from mildly symptomatic to symptomatic, we have docetaxel and the option for radium-223. And then post-docetaxel, you have the AR agent you haven't used as yet, and then as well as the option for cabazitaxel. And it shouldn't be as a subnote, but it should be fairly prominent that we should use supportive care with denosumab and bisphosphonates. And these bone-targeted therapies are important. And I think the purpose of this program is to go over the spectrum of management of prostate cancer patients, but also to talk about the role for these bone-targeted therapies during the spectrum of the disease. I think often they're overlooked now, and I think we need to keep them in mind as we go through our treatment options for our patients. This is changing very avidly, and again, with the introduction of darolutamide and apalutamide and other drugs, it makes it more complicated, and we'll try and sort that out in the next half hour or so in this program. Many of you have seen this again, and this reiterates some of the previous slide, is that when you have the PSA load and you have local therapy, and then first line hormonal manipulations, and then second line hormonal manipulations and non-metastatic disease, a progression to non-metastatic castration-resistant prostate cancer, which is a space that many of us are interested in now. And then it evolves to metastatic castration-resistant prostate cancer with these various agents, and the sequencing is important to try and sort out. That makes it very complicated. For example, if you use abiraterone now in hormone-sensitive disease, what do you use after progression, and should we go straight to docetaxel or consider another agent? And again, that makes it fairly complicated, and we'll try and sort it out. Now, the purpose of this program is to talk about the bone morbidity across the spectrum of prostate cancer. And we have this, when you have ADT, these are hormone sensitive, and you're at risk for CTIBL. Again, this stands for cancer treatment-induced bone loss and fragility fractures. These are patients that do not have bone mets and are hormone sensitive, but they're at risk for cancer treatment-induced fragility fractures and other morbidity. And as they go to the M0 castration-resistant space as well, again, they do not have metastases, but are at risk for some morbidity from the treatment that they're receiving, and we need to keep in mind the bone-targeted therapy piece. Even though we're prolonging overall survival, they can still have bone morbidity that we need to keep in mind. And then once they do develop bone metastases, eventually we have SREs that we have to try and prevent, and that's where we'll go through some of the bone-targeted therapy data that's been well established. So let's talk about cancer treatment-induced bone loss first. So what we do know is that ADT does lead to increased fragility fracture rates. This is a study by Shahinian from New England Journal in 2005, quite a while ago, that shows over a SEER database review of thousands of patients from 2005, that over a 4-year period, you have a 19% risk of fractures on ADT or hormone therapy, and 12% risk of fractures not on hormone therapy. And so there is a significant difference from 19% versus 12% not on ADT in this SEER database. And these are fragility fractures on the hormone therapy. So I think this is significant to note. And there's another more recent study by Xiao as well in 2013, which looked at the SEER database again and look at the incidence of fracture among patients with prostate cancer. And certainly those patients were at high risk, were on ADT versus no ADT high risk, were at high risk for fractures. Now, this is a composite score that Xiao et al. Looked at 76,000 patients, and the risk factor index that they looked at, this skeletal complication index, were patients that were over the age of 80. They had diabetes, potential alcoholism, cigarette smoking, rheumatoid arthritis, liver disease, and history of osteoporosis and fracture. And with these patients, if they had any of these, more than one, they were at risk they were considered high risk, and certainly their risk for fracture was much higher, 19.9 for 1,000 person years compared to no ADT and high risk. If you had none of those criteria, you're still at significant risk for fracture on patients with prostate cancer. And you can see those curves are divergent, showing that ADT does have some morbidity for fracture risk among patients with prostate cancer. So who should be treated for this? Now that we know that the burden of this disease is significant, we have to try and look at those patients that are on ADT, on hormone therapy, and should we try and treat them? So this is where we need to do bone mineral density testing every 6 months to a year or so on these patients with hormone therapy, and look at their T-score. If their T-score is less than 2.5, then they're considered osteoporosis, and they should be treated. If they have a T-score of less than negative 1.0 with the risk factors that we talked about on the last slide, then certainly they're also at risk for morbidity from bone disease, and they should also be treated as well for this. This is important to monitor these patients with a bone mineral density every 6 months to a year as they move through their course on ADT. This is the treatment algorithm for men undergoing ADT. You assess their bone mineral density. Again, we want to do this every 6 to 12 months. And if their T-score is less than negative 2.5, they're considered osteoporosis and should be treated to prevent any fracture. If their T-score is negative 1.0 to negative 2.5, this is osteopenic, and they should be given calcium and vitamin D for all these patients. What I use is 1,000 milligrams of calcium and 1,000 milligrams of vitamin D. And treat if their risk factors or repeat their bone mineral density every 6 to 12 months. And if the T-score is greater than negative 1.0, then repeat their BMD every 2 years or so. And again, this is an important algorithm. And these were patients that could consider for denosumab, 60 milligrams every 6 months, otherwise known as Prolia, as an option for these patients as well. So what about allogeneic? This is also known as Fosamax. This is a study by Greenspan in 2007. This increases bone mineral density during ADT therapy over 12 months. You can see here, looking at lumbar spine, if you had placebo, your bone mineral density depreciated quite significantly. If you were on the Fosamax or the allogeneic, certainly you had an increase of 3.5 BMD on the Fosamax with ADT. Not as dramatic with the hip BMD, but certainly with the femoral neck as well. It's a 1.5 increase over negative 1 on the placebo arm. And so this was significant, showing that adding on Fosamax or allogeneic in this patient population did help to increase their BMD over the 12-month period. As well as the zoledronic acid on the lumbar spine, you can see a dramatic difference. These are patients that received, all patients that received zoledronic acid, GnRH or GnRH with complete androgen blockade with an anti-androgen. If they had complete androgen blockade, they have a more significant response on zoledronic acid. But even on GnRH alone, or with a combination there, or altogether with combining these groups, you can see that there was a mean change in the lumbar spine BMD to 5.6 which is very significant compared to placebo at negative 2.2. So this did increase their bone mineral density and decreases their risk of C-Tibble on zoledronic acid. How about denosumab? This was again 60 milligrams Q 6 months, otherwise known as Prolia, or Xgeva as the 120 milligrams Q monthly. And you can see here that on this 60 milligram dosing by Smith's study back in 2009, the lumbar spine increased dramatically compared to BMD compared to the placebo, and the difference at 24 months was 6.7 percentage points, and that was in the lumbar spine, as well as 4.8 percentage points in the hip, showing that the addition of this denosumab on an ongoing basis did help their BMD during ADT, decreasing the cancer treatment-induced bone loss over time. Also out of that same study, denosumab reduces vertebral fracture during ADT in non-metastatic prostate cancer. And you can see here that the vertebral fracture was 13 in placebo versus 2. And this was quite significant, reducing the fracture risk on ADT, receiving denosumab, again at this dose of 60 milligrams every 6 months or so. So that's the burden of ADT in patients receiving, the burden of bone disease in patients receiving ADT. I think is very important to try and minimize that and keep on top of the bone mineral density and treat appropriately to minimize the morbidity of their hormone therapy that they can be on. Always reinforce that they should be on vitamin D and calcium while they're on their hormone therapy as well. So what about this hormone-sensitive prostate cancer space? This is an evolving space, lots of new data that's come out of this. And the charted, many of you have seen this quite a bit, but just to reiterate, in the high-volume disease, there was a significant benefit with ADT plus docetaxel versus ADT alone. Again, this is docetaxel, 75 milligrams per meter squared, given every 3 weeks over 6 cycles. Again, over 4 to 5 months, these patients received their docetaxel plus their hormone therapy. And these high volume was patients who had visceral mets or greater than equal to 4 bone lesions, with one of them beyond the spine and pelvis. That was the definition for high volume. There was less of a benefit out of ESMO last couple of months ago in the low volume disease, but certainly in the high volume disease patient, this has been shown to have a dramatic difference in the overall survival at 57.6 months versus 44 months. Now, without some morbidity, there is about a 12% neutropenia and fever rate. Grade 3 to 4 infections can happen as well. So there is some morbidity with docetaxel, and this needs to be kept in mind. We also had Stampede. Stampede, as you know, is a multi-arm study out of the UK, and with docetaxel plus ADT versus ADT alone, there's a difference of 60 months versus 45 months, reiterating the advantage of high volume disease responding to docetaxel plus ADT. Now, these are impressive numbers. If you look at this chart here, looking at all the studies that are out there, and I want to thank Alan Stowe for giving me some of these slides. This does show that in the Stampede and Charted, you can see that the advantage of docetaxel versus ADT alone is plus 15 months. Again, in the Charted as well, plus 14 months. So very dramatic differences compared to patients in the pre-docetaxel and metastatic CRPC. Very good overall survivals, as well as post-docetaxel treatments, as well with enza and abiraterone, as well as radium. Significant overall survival advantages, but not as dramatic, and certainly in the hormone-sensitive space, which has led us to change practice for these patients based upon these studies. A third study that's come out and changed practice for many of us is this Latitude study, which is just recently released at the ASCO annual meeting. This is in a phase 3 double-blind randomized trial of androgen deprivation therapy with abiraterone acetate, prednisone, or placebo in newly diagnosed metastatic hormone-naive prostate cancer patients. Now, the definition of high risk in this study was Gleason greater than 8, greater than 3 bone lesions, and visceral disease. So similar to the Charted population, where there was 4 bone lesions and visceral disease, and certainly a high-risk population. And they were randomized to abiraterone acetate plus prednisone versus ADT plus placebo in these high-risk patients. Again, visceral metastases, as well as Gleason 8 and greater than 3 bone metastases. Endpoint was overall survival and radiological progression-free survival. And we saw in this study a 38% risk reduction of death, which is very impressive, and very pleased to see this at follow-up of 30 months. Now, without some side effects, abiraterone is a very well-tolerated drug, but you need to be aware of the side effect of hypertension, hypokalemia, increased liver function test, and a subset of patients, hyperglycemia. So you do need to monitor this as they go through their treatment. Now, we talked about the fact that docetaxel is Q3 weeks for 6 cycles over 4 to 4.5 months or so, whereas in this study was out to 33 months, so median follow-up was 30 months on this. So they're on an ongoing basis receiving their abiraterone in the study. So it was a significant improvements in all secondary endpoints. You can see their time to PSA progression was very impressive for abiraterone plus ADT versus ADT plus placebo. Time to pain progression favored, as well as time to a symptomatic skeletal event, and time to chemotherapy, as well as to subsequent prostate cancer therapy. Very impressive results out of ASCO. And in this, we were very pleased to see that overall survival had a 38% risk reduction in risk of death, 30% reduction in risk of death, and prolonged radiological progression-free survival. So this was a good result, and in fact, when this came out at ASCO, we had some patients ask for this just the day after it was released in terms of the press. And I had a patient that requested this the Monday after the ASCO meeting, and he's currently on this as well already, based upon latitude, and he's doing well on abiraterone in his hormone-sensitive, high-volume state. So we compare this again; they're fairly similar. Just to reiterate again, meets 2 or 3 of the high-risk criteria: greater than 3 lesions of bone scan, measurable visceral disease or Gleason score 8 in the latitude population, and charted was more than 4 on bone scan, meets 1 or both criteria, and measurable visceral disease. If you put in Stampede as well there, you can see that the overall survivals are impressive. 34 months, hazard ratio, 34 months versus not reached in latitude versus 34 versus 51 in charted, and hazard ratio of 0.62 and 0.63, 0.63 in Stampede. Very similar for both studies. We're not supposed to overlay studies, but if you do overlay the latitude with the charted, you can see they're almost superimposed. You can see that docetaxel and abiraterone are very similar curves compared to ADT alone. Interestingly, how the ADT alone charted and latitude arms are also very much superimposed, showing that this is reproducible data and very similar in terms of their outcomes. So we don't like to compare studies like that, but they did each have a hazard ratio for death of 0.6, similar 3-year change in overall survival compared to control, 65 versus 50%, and each resulted in a hazard ratio for progression of 0.5. We do have some unanswered questions for resistance. Things here that I like to look at is, does adding chemotherapy or abiraterone to ADT result in a more aggressive state at the time of resistance? So my patient that's on abiraterone in the hormone-sensitive space, when he progresses to castrate-resistant prostate cancer, what am I going to put him on? I would imagine we'll probably put him on docetaxel straight away, but perhaps there's a road for the AR agents such as apalutamide or darolutamide or enzalutamide. Really don't know, but perhaps it may be a more aggressive state, and maybe they should go straight to docetaxel for abiraterone. But if they progress on docetaxel in the hormone-sensitive space, what are we going to do after that? And these are unanswered questions that we're trying to grapple with in sequencing now. Well, is there also going to be an increased risk of small cell neuroendocrine prostate cancer? That's also a concern, and then it remains to be seen whether you're going to have more aggressive cancers in the future. Will there be androgen receptor amplification? What are the mechanisms of resistance that we'll have to see as it progresses? And what's the optimal therapy who progresses on these therapies? And those data will need to be seen as to what to offer those patients. So There's also STAMPEDE as well. So STAMPEDE looking at abiraterone with high-risk prostate cancer with androgen therapy. STAMPEDE is a multi-arm study for inclusion in multiple trials, and this is the schematic of what they've offered in this trial, multiple arms that are ongoing. ADT plus zoledronic acid plus docetaxel plus Zol plus docetaxel combination plus abiraterone, and also you can compare abiraterone to the docetaxel. In this next few slides, I'm going to compare STAMPEDE abiraterone acetate plus the ADT standard of care. And you can see here, this also does mimic some good results from abiraterone acetate, and the hormone-sensitive space is important, and it shows a 37% improvement in survival with the abiraterone plus ADT versus ADT standard of care alone. Now, the skeletal-related outcomes were also improved. There's a 55% reduction in skeletal-related events with abiraterone, both out of Latitude as well as out of STAMPEDE. And it's important to keep in mind, though, is that you still need to keep in mind the bone-targeted therapy piece for this, because they still are going to get skeletal-related events. They still have the morbidity of getting their ADT on an ongoing basis. And we talked about at the first few slides the C-Tibble piece, where the ADT does cause osteopenia, osteoporosis. Even while they're on these drugs, there's still the risk for cancer treatment-related bone loss, and that needs to be kept in mind while they're on the therapies. Even though we do have decrease in the skeletal-related outcomes, they still occur and needs to be kept in mind during the course of their therapy. So in hormone-naive prostate cancer, ABI plus prednisone improves survival by 37%, failure-free survival by 71%, SREs by 55%, well tolerated. There's still some side effects that need to be kept in mind. We need to monitor these patients, but otherwise they do very well on abiraterone with prednisone. So what about comparing which is better? So we talked about Charted, we talked about Latitude. What about comparing the two? In the STAMPEDE, this was presented at ESMO a few months ago, looking at abiraterone versus docetaxel and those patients on ADT. And this was the combination in here. You can see docetaxel plus ABI, and they compared this together in terms of patients, 189 patients on docetaxel plus ADT versus 377 on abiraterone plus ADT. And they're randomized to each arm. And you can see here, actually, this is quite interesting data suggesting that patients may benefit more with the ADT plus hormone therapy versus docetaxel versus hormone therapy. So the failure-free survival, the hazard ratio is 0.51. And if it's less than 1, favors abiraterone plus ADT versus docetaxel. And so this was impressive, showing that there was a trend and a failure-free survival advantage with abiraterone versus ADT versus docetaxel plus ADT, and this was significant p-value. Same with progression-free survival. You can see here as well, the hazard ratio is 0.65, again favoring abiraterone. You can see the differing in the curves, and this was also impressive data for the comparison. However, for the skeletal-related events, about the same, hazard ratio 0.83, perhaps favoring a bit the abiraterone versus docetaxel. And you can see those curves are pretty similar, but did have a hazard ratio of 0.83. Overall survival wasn't that different, however. You can see the curves are fairly superimposed. And so we still don't know which one is better to offer patients versus abiraterone or docetaxel in the hormone-sensitive space. But certainly urologists would be more prone to offer abiraterone. We know how to manage this drug, and maybe something within the urologist armamentarium, having known that overall survival is not that different. However, you do need to keep in mind that the abiraterone is an ongoing therapy, whereas the docetaxel stops after about 5 months. So looking at the summary of this, you can see the failure-free survival and the progression-free survival, strong evidence favoring abiraterone, metastatic-free survival, weak evidence favoring abiraterone, but overall survival, again, pretty much similar for this. So looks like that's what the data is so far out of ESMO just a month ago or so. So that's the hormone-sensitive space. And again, in the M1 SRE prevention, It's very important, even though we have all these great new options for patients now, and again, options for the urologist to offer your patient. You can put them on a hormone-sensitive space. Once approved, consider abiraterone for them. It does decrease their skeletal events, but you do need to keep in mind the spectrum of the disease. Again, reinforce that they're on their hormone therapy for a long time in combination with other therapies, and the risk for cancer treatment, bone loss. Consider the bone-targeted piece to decrease the morbidity of this. So there is still a role for the bone-targeted therapy piece, and don't forget to do the bone mineral density every 6 months to a year to watch for any osteoporosis or osteopenia requiring some therapy. So again, just to reiterate, 30% risk of reduction of a symptomatic skeletal event, but they do occur, and you need to monitor, watch for them, and keep an eye out to screen for the development of bone metastases and castrate-resistant disease. Again, doing the proper CT scan imaging and bone scan imaging, as well as a bone mineral density on an ongoing basis while they're on their hormone therapy. So just moving on now, we're going to go to the M0 space. And you can see that even in this, it's not even properly captured in this schematic. Hormone sensitive to metastatic castrate-resistant, but now the new space is the M0 space. This is changing very quickly in the non-metastatic or M0 space castrate-resistant prostate cancer. We have some guidelines. We are going to update these shortly through the guidelines committee, which I happen to be quite involved with, and we're going to do an update of this shortly because there's so many new therapies, especially the non-metastatic CRPC. We recommended in 2015 a secondary hormonal manipulation and keep screening for metastases based upon the doubling time. This is important. I want to reinforce this, and that we're going to talk about the 147 study that showed that the doubling time of 8 months or less is very important. 8 to 10 months or less is very important, as the bone metastases risk increases exponentially. And we saw that out of the 147 studies. And so based upon your patient with the M0 space, you do need to screen for these metastases very aggressively, depending on their PSA doubling time, and consider hormonal maneuvers. We have a number of new options that are going to be offered shortly, and I'm going to go through those briefly. We've talked about, again, the morbidity across the continuum. And again, this is the space we're talking about today, right now, in this slide. Castrate-resistant prostate cancer, M0, risk for SREs depending on the PSA doubling time and fragility fractures, as well as bone destruction. So these are the studies that have been offered out there. And again, the DMAB, denosumab, is a 147 study in the M0 space we're going to go through. And the CRPC space, M1 and M1 post-chemo, multiple studies we're going to touch on briefly. But interestingly, the 147 was the only randomized trial in the M0 space, and we'll discuss that right now. The bone metastases-free survival in patients with a PSA doubling time of less than 6 months was significantly higher in the denosumab arm. So you had a 23% risk reduction if you were on denosumab compared to placebo at 25 months versus 18.7 months, seven months longer in the denosumab group. So this is important, and we've had some discussions about metastases-free survival being a surrogate endpoint for overall survival. Many of us do believe that the MFS is a surrogate for overall survival. There's a recent editorial in JCO reinforcing this, and I would agree that we can use this as a surrogate, and certainly denosumab does have a 23% risk reduction in non-metastatic M0 CRPC and PSA with a doubling time that's very quick. These patients are at very high risk, and this is the schematic that shows that if you have a PSA doubling time over 10 months, then their risk for metastasis or death is quite low. But once you hit a PSA doubling time of 8 months or less, it goes through the roof. You can see the risk for bone metastases or death is exponentially high out of the 147 study, and very significant to keep in mind. These are the recent studies that have been completed in non-metastatic prostate cancer. I'm not going to go through all of them, but I want to touch on the 147 again here in the middle here, metastases-free survival, showing prolonged bone metastases-free survival. The only significant trial on this table, actually, the atrasentan trial that many were involved with, was a negative trial, unfortunately. and this is an endothelin A receptor antagonist. We were involved in those trials back many years ago. Bevacizumab, which is a anti-VEGF antibody, was also a negative trial, showing no evidence, no benefit in non-metastatic CRPC, as well as orteronol as well was a negative study, and this drug is not pursued any further in the M0 space. But we do have some other options coming up. We have darolutamide. Many of us in the audience may be involved in the darolutamide Aramis study. I know that we were involved in that at our center. And this is an androgen therapy that has been studied in the M0 space as well as the hormone-sensitive space. And we're waiting for the results of this trial, which is now closed with bated breath. And there was also the ARN or apalutamide study that looked at non-metastatic castrate-resistant prostate cancer. Matthew Smith published this phase 2 cohort showing some activity in this space, which led to a phase 3. And this is just released about 2 or 3 weeks ago, where Janssen has applied to the FDA for apalutamide to treat men with non-metastatic castrate-resistant prostate cancer. I'm sure that Canada will follow, and this Spartan study will be presented at a meeting shortly, I assume, either GU ASCO or ASCO, and we'll see the results of this Spartan study. But if they're filing for the indication for non-metastatic castrate-resistant prostate cancer, it looks like it may be some good news for men in this space. Same with the enzalutamide or Xtandi in the Prosper study. They also did a press release last month or a month or two ago, showing that it demonstrated a significant improvement in metastases-free survival in this patient population, which is non-metastatic prostate cancer in a randomized controlled trial. So they're also probably going to file for this indication through the FDA and Canada following. And this is also will increase the metastases-free survival, which we anticipate is a surrogate for overall survival in this patient population. So right now, there's no drug approved for the M0 non-metastatic prostate cancer space, but enzalutamide as well as apalutamide will probably be coming through your door shortly, and perhaps darolutamide. And always consider the bone-targeted piece, because the denosumab has shown to significantly help patients compared to placebo in this space as well. All right, so we're going to move on to the bone-targeted therapies and the management of metastatic CRPC. Many of you are familiar with this space. So the previous slides are touching on some new data. And this is some data that you may be familiar with, but we'll fire through this so you're up to date on what's happening in this. So, and we'll also have some new data in this space as well. So this is, again, the guidelines, and with minimal or no symptoms, we've been through this a little bit, so I won't belabor that. I always consider the bone-targeted therapy piece as per the CUA guidelines, CUA guidelines, recommended to reduce the risk of skeletal complications. So we do have a recommendation that if you have CRPC, that you should use bone-targeted therapy. And this is covered as well through public payer in this space as well. And we're now working at this space in here, the bone destruction and SRE space. And we do know that bone complications have a fair amount of morbidity. If you have bone metastases, you're at risk for fracture, radiation to bone, spinal cord compression, surgery to bone, hypercalcemia. All these consequences have reduced quality of life and decreased survival. So the bone complications have a lot of morbidity, and we do need to keep in mind for this. And this is just a slide showing that the impact on the healthcare resource utilization is pretty significant. If you have a spinal cord compression, or you have surgery to bone, your hospital stays are numerous. The cost implications are numerous for patients. Pathologic fracture, radiation to bone, and so the resource utilization is very high if they get an SRE. So prevention of this is a very important thing to keep in mind as you're treating your patient with these multiple therapies. This is a slide from Fred, again showing that the pathologic fractures are associated with increased mortality. You can see this, that if you have prostate cancer patients and their hazard ratio is a 1.29, 1.23, increased mortality for those patients, a relative risk increase of 29%, 23%, and associated mortality. So it's important to remember that when they get an SRE, their longevity is shortened based upon some of this data. And so it's very important as you consider your patient on abiraterone, enzalutamide, docetaxel, cabazitaxel, radium, that you don't forget the bone piece as well, because their morbidity is very high if they get an SRE, and so you need to keep that in mind through the spectrum of your treatment. This is a study out of the this is a veteran study looking at those patients that the SRE is associated with increased mortality. They looked at non-metastatic CRPC and followed the spectrum of these patients through metastatic CRPC with bone metastases. And in a univariate analysis, the hazard ratio is 1.54 associated with increased mortality. And if you look at the multivariate analysis as per this slide, hazard ratio is still 1.67 associated with increased mortality. And so these are important, another important data set to keep in mind for the morbidity of this. This is another study looking at metastatic sites of conversion from M0 to M1 disease in CRPC. And the purpose of this slide is just to be vigilant that if you don't do a CT scan or bone scan in these patients, you may miss metastatic disease. So I think that many of us have already changed our practice, unlike what we used to a number of years ago, whereas patients with metastatic CRPC, we do, or even M0, we do more bone scans, more CT scans every 3 to 6 months, based upon various triggers of PSA change or just time on therapy. And we look for metastatic disease, and if you don't do the CT scan or bone scan, you may miss some disease that you might have otherwise picked up. And this does lead into discussion of PET scanning, and we'll see how PET scanning changes the treatment paradigm for our patients as we pick up more metastases with gallium PSMA PET, and we'll see how that pans out in the near future. So just to talk about some of the benefit of zoledronic acid with reduced risk of SRE regardless of pain. This is a slide showing that if your patient is asymptomatic, they're still at risk for SRE, and patients with no pain at baseline, they have almost a 40% relative reduction of SRE with zoledronic acid versus placebo, versus an 18% relative risk reduction in patients with pain. So if you have a patient with an asymptomatic bony metastases with metastatic CRPC, they could have significant problems. So in this, you want to reduce the risk of SRE. Even if they have no pain, they can benefit from bone-targeted therapy. Prior SREs are associated with increased risk of subsequent SREs, and you can see that untreated patients with bone metastases from prostate cancer who experience an SRE were at increased risk of developing subsequent SREs. So if you had one SRE, you're very high risk for subsequent SREs, and also keep that patient in mind for therapy as well. This is a slide that many of us have seen over the years, but a very important slide nonetheless. This shows Fazazi's trial versus Fred Sad's trial, looking at the first-time SRE on zoledronic acid. And you can see the time from first SRE is 16.3 down to 10.7 months in the zoledronic acid versus placebo arm. And if you look at Fazazi's trial, it's 20 months versus 17 months, denosumab versus zoledronic. And if you look at these side by side, you can see going on denosumab, it's 20 months time to SRE, first SRE, compared to 10 months on placebo. So side by side, you can pretty much double the time to first SRE if you put them on a bone-targeted therapy as opposed to not. Out of Fazazi's trial, you can see again, looking at this, that denosumab versus zoledronic acid, a 3.6-month advantage to first on-study SRE. So take-home message, your patients with metastatic castrate-resistant prostate cancer, denosumab will delay their onset of first SRE, as well as zoledronic acid will delay it. And both these agents are excellent agents to help your patient delay your onset of SRE and decrease their morbidity from it. DMAB reduce the number and first onset of reduce the number and first and subsequent on-study SREs. And you can see there that the events are quite a bit less of the denosumab. More evidence showing that the cumulative mean number of SREs per patient is less with the bone-targeted therapy. So just to finish off, what about other therapies? So many of our patients are on denosumab, they're on enzalutamide, abiraterone, radium, and so on. Is there any evidence to say that concomitant therapy is useful? And in fact, there is. This is a post-hoc analysis of Dr. Sad's study looking at of the Cougar 302 study looking at abiraterone plus prednisone in the chemotherapy naive setting, combined use of BTT and abiraterone. Again, post-hoc analysis, so with a grain of salt and hypothesis generating, but provocative, showing that those patients that had prior BTT use did better than no prior BTT use. You can see the difference in the radiological progression-free survival as well as overall survival. Very provocative that going on a bone-targeted therapy, these patients did better with abiraterone than no bone-targeted therapy. Time to opiate use, time to chemotherapy initiation, time to performance status deterioration, time to PSA progression was about the same. But these other endpoints are impressive in terms of concomitant BTT and abiraterone was a benefit. Again, a post-hoc analysis and hypothesis generating, but provocative data nonetheless. L-SIMCA as well. This is looking at radium-223, where radium-223 has an advantage in patients on placebo, having an overall survival, leading to the registration of radium-223 for patients in Ontario. And what you can see here is that those patients that had concurrent bisphosphonate use actually did better than without it. So 19.6 months versus 10 months versus no current bisphosphonate use, 11 months versus 8 months. So it's suggestive that those patients on BTT did better if you compare these side by side, 11.8 versus 19.6 versus placebo 10.2. So certainly it does appear that the concurrent use of BTT, bone-targeted therapy with radium, is also of some additive benefit in this analysis out of the L-SIMCA trial. You can see here the early access program as well, overall survival, showed that the concomitant use of denosumab over no denosumab had some overall survival advantage. Again, not significant in this trial, but did show some advantage to this, and so that's more evidence that concomitant use of radium with BTT is beneficial. We're going to finish off with 2 slides out of the Ottawa group. So the Ottawa group did a retrospective analysis of about 300 patients, looking at patients on their novel agents with docetaxel, abiraterone, and enzalutamide. Looked at those patients on bone-targeted agents, zoledronic acid, and denosumab. And again, they did follow them for about 75 months. And they showed those patients that had a BTT, they did better with less SSEs and less need for bone radiation than those patients that did not have a bone-targeted agent. Those patients that did not receive one had more SSE and more bone radiation. Some real-world evidence presented out of ASCO last year that, or this year, that the concomitant use has a benefit in this retrospective analysis. And in the same retrospective analysis of these patients, the SSE rate was quite a bit less than the 2.8% of the BTA agent versus without it. And the time to SSE was also prolonged in those patients on the BTA. Now, they did look at overall survival in this, and there was actually no difference, but again, it's a provocative analysis and retrospective with its inherent biases, but does show, again, concomitant therapy for these patients does decrease the time to SSE for these patients and of benefit for these patients. So I think I've been about maybe a little bit longer, about 40 minutes, 45 minutes, but I think we went through the full spectrum of the patient with castrate-sensitive prostate cancer to castrate-resistant prostate cancer, as well as the M0 space. This is my last slide saying that the M0 space, we have good data with abiraterone and docetaxel in those studies I presented. But remember, you've got to keep in mind that these patients are still on ADT with all those agents. So while they're on that, they need to take their vitamin D, they need to take their calcium, they're at risk for cancer treatment-induced bone loss. Consider bone-targeted therapy to increase their BMD. Keep an eye on them with their BMD every 6 months to a year. Keep an eye on them with the bone scan and CT scan on a periodic basis as well to watch for any bone complications. In the M1 space, SRE prevention with BTT, we have the 147 data we talked about. Again, the only data so far that is a randomized controlled trial that has read out in the the M0 space, I should say. In the M1 space, the SRE prevention with BTT. In the M0 space, again, still on ADT, consider risk for C-Tibble. And certainly in the metastatic space, SRE prevention is well established, and you should consider SRE prevention for your patient with a bone-targeted therapy. So I want to thank you for your time. I know it's a tour de force of the full spectrum of prostate cancer and bone-targeted therapies and how they fit in. I'd be glad to answer any questions you may have, and I appreciate your attention.
Thank you, Dr. Kapoor. I will open up the floor to any questions. There are a few that have come in through the chat. The first is a question specifically regarding the Fosamax study early on in the presentation, and the question was the compliance to the oral adequately controlled, or was it more in a real life setting, based on the slide that you presented at the beginning in the C-Tibble space?
So that's a good question. In my experience putting patients on Fosamax, the compliance is not as high because of the main side effect is diarrhea. So many of these patients, they get 70 milligrams of allogenate every week, and the diarrhea does affect compliance with that for sure. And so that's where other agents may be better because they don't have that side effect of diarrhea, and I don't use it that often because of that. Certainly as a urologist, it's easier to use denosumab as a outpatient in your clinic, as opposed to ordering IVs zoledronic acid and occupying chair time at the cancer center or in your clinic. And Fosamax, again, the side effects of diarrhea can be significant.
There's a question. Thank you very much for that answer. If the individual who asked the question, if you have any follow-ups to that, then please let me know. There is a question on, just one second here, I'm trying to catch up to them. So in Quebec, first of all, thanks for an excellent presentation. Denosumab is only covered when there are bone mets. Do you use Fosamax with prolonged ADT use, is the question.
So that's an excellent question, and you're right. So what I try and do is get it covered through private insurance. So if they don't have private insurance, it's hard to get it covered through the government, and that's been an issue because it's not covered through that. If I can't get it covered through private insurance, then I'll try Fosamax or one of the new agents, or I'll consider them for a referral to one of our local rheumatologists. They often help us with clinical trials that they're running in this space as well that we're not involved with, and they can also access some of the newer agents that may be of some benefit. Try private insurance first. If that doesn't work, then it's hard. It certainly is hard to get it covered. I agree. It's covered for sure in the metastatic CRPC space, and that's where we want to. I think what we've seen is that that bone piece is overlooked now with all these new patients. Again, it's very complicated. You have a patient that comes in, they're on abiraterone, they're on prednisone, they're on their hormone therapy, and you're trying to manage their hormone therapy and manage their abiraterone side effects and blood work and their PSA kinetics. And so you do have to keep in mind their bone targeted piece, and always keep that in your mind.
Okay, another question here. What is the maximum length of time you can give denosumab?
It's a good question. I tend to keep them on it for a couple of years, and the ONJ and hypocalcemia risk is low. Usually the hypocalcemia happens in the first few months. If it doesn't happen then, it's likely not going to happen, so that's not really an issue. And the ONJ, again, you do keep in mind examining their mouth briefly on every visit, unless they're in the home injection program. And after a couple of years, I tend to stop because of the risk of that long term.
Any other questions?
Or sorry, I should give a caveat. Or I'll spread it out a bit. I mean, we do give it 120 milligrams every 4 weeks. Sometimes we'll put patients on it every 3 months or so after a couple of years and try and stretch it out a bit.